Mhm.
Good morning.
Good morning.
How are you?
Good.
Morning.
Good morning, Miss Sheria.
Thank you both for finding time for this morning.
I'm excited.
Just check to see if there's any emails that have to be followed up with regard to this. So be right back.
post the real event shortly. Okay, hello.
Good morning.
Oh, good morning. I'm Jack Nolish, Jeffrey's dad. How are you?
Doing well.
Good. Excuse me, I will be right back.
Okay.
But I'm not.
No, she can hear you though.
How do I turn
Jeff's mom just joined us.
Good morning.
Good morning.
You need to.
Good morning, Lisa. How are
Good
you
morning,
doing?
Els. How are you?
Good. We are in the snow here.
Oh,
A little bit. It's just pretty. Yeah.
well, that's good. That's good. It's on the cool side here, but definitely no snow.
Good, good. And you feel all established there. Good morning, Michelle. Oh, there. Oh, she's still muted.
Hi, Els. Nice to see you in
Hey, there
person.
you are, Elizabeth. That's good to see your face. It's very nice.
Yeah.
I want to thank you for all your hard work.
Thank
And
you for.
sometimes I'm duplicating certain messages to you, but at least I'm thinking. And I'm working on it. So
Me too. Lot going on.
yes, yes. Gosh, this is a large group.
Nice. And hopefully we should have a few more in a few minutes, but we may want to put things together. So today is not, we're fortunate that we're having a panel discussion rather than our usual meeting. So I'm going to likely ask folks to mute themselves, and optional whether or not you want to keep your camera on. We do have the, we should have recording. Let me just double check that in terms of, oh, wow. Okay. Nice attendance. I'm looking at everyone on here. I know we have the live recording, but I thought we also might have had the closed captioning as well. So I'm just trying to find that and specific to who that is. And then we will start in a minute.
Michelle, sorry to interrupt. Do I need to reach out to Letty, or have we tried to assign the captionist?
That's what I'm trying to do right
Oh,
now.
okay. Just let me know what I could do to help on the background.
Right. If you want to reach out to her to see if they're on, that would be great. Thank you.
I'll do that. Okay.
Recording in progress. Good morning.
Good morning.
How are you? Good to see you.
Good morning. Nice to see you as well.
Thank you all for being here. We will be starting in just 1 or 2 minutes. We are just trying to determine the source of the captioning right now. Okay. Thank you all for being here this morning. Hello and welcome. This morning, the University of Michigan Center for Disability Health and Wellness and the Ideal RRTC are delighted to host Partnering to Create a More Accessible Future, a panel conversation on ableism and racism in healthcare. As a reminder, the vision of the Center for Disability Health and Wellness is of working in partnership with members of the disability community to ensure that all people, regardless of type or severity of disability, have full access to quality health care and to wellness activities personalized to their backgrounds, strengths, and needs. As such, we believe that conversations such as this one are critical to ensure a better future. Today, we are very fortunate to have 4 panelists and disability activists who are working in their communities to create change. I will introduce them and then we will start with the conversation. One note about protocol, please keep yourself muted throughout the event. If you have a question, please type it in chat and I'll work to ask it to the panelists at the appropriate time. So I'm going to just introduce them briefly. Ms. Tameka Citchen-Spruce worked for Beaumont Health, Healthy Dearborn, where she started and leads the Inclusive Health Committee, which is comprised of people with disabilities, their families, and people who work with them. She served as Miss Wheelchair Michigan in 2006 with a platform on supporting women with disabilities who are being abused. She is a member of Warriors on Wheels of Metropolitan Detroit, a volunteer of the Muslim Anti-Racism Collaborative, and a disability ambassador for the World Disability Institute, where she represents people with disabilities at the Congressional Black Caucus Annual Conference. She is also a talented filmmaker and has over 15 years experience in disability advocacy and media. Ms. Jaime Junior is a committed and passionate advocate for the needs of Detroit's disability community. She serves as the Chief Operating Officer for Warriors on Wheels of Metropolitan Detroit and is a member of the Michigan Developmental Disability Council, an advisory group under Michigan Department of Health and Human Services, and she is an Associate Fellow for the Pulse Institute's Academy of Fellows focusing on disability rights and poverty. Mr. Jeffrey Nolish is a policy director for Detroit Disability Power. Concurrently, he serves as a senior airman in the Michigan Air National Guard and U.S. Air Force. Previously, Mr. Nolish served as a policy advisor to Governor Gretchen Whitmer, special advisor to Democratic Lieutenant Governor candidate Garland Gilchrist II, mobility specialist at the City of Detroit Planning and Development Department, and policy analyst and community advocate to Detroit City Council member Raquel Cataneda Lopez. He is also a Detroit Revitalization Fellowship and AmeriCorps alum who earned his MPA from DePaul University. Dr. Robinson-Lane is an assistant professor of nursing at the University of Michigan in the Department of Systems, Populations, and Leadership. As a gerontologist, Dr. Robinson-Lane has expertise in palliative care, long-term care, and nursing administration. She has focused her administration on the care and support of older adults with cognitive and functional disabilities. She is interested in ways that older adults adapt to changes in health, and particularly how adaptive coping strategies affect health outcomes. Her research is focused on reducing health disparities for minority older adults with cognitive impairments and their informal caregivers. I am Michelle Meade, Director of the Ideal RRTC and Co-Director of the U of M Center for Disability Health and Wellness. I will serve as the moderator for this meeting. As we start, I just want to thank you each for being here. Can you start by telling us a little bit about your organization, or for Sheria, your research, and about the work that you're currently doing in the community? I'll start with Jaime.
Good morning, everyone, and thank you for having me here today. I'm so pleased to be before you. I work with Warriors on Wheels of Metropolitan Detroit. We are a disability justice organization for individuals with disabilities, by individuals with disabilities, more specifically women with disabilities. For the past 15 years, Warriors on Wheels of Metropolitan Detroit has advocated for citizens of the city of Detroit regarding various issues. Transportation, as a matter of fact, Warriors on Wheels participated in a ghost riding program with the Detroit Department of Transportation to ensure that individuals with disabilities receive equitable service when utilizing public transportation. We also work with Detroit People's Platform in various arenas, including housing and advocacy for the community benefits agreement for the citizens of the city of Detroit around equitable access to city services and affordable, accessible housing. Additionally, I've had the great pleasure to work with the RRAC IDEA project as a research assistant, helping to recruit individuals to participate in their research for the purposes of finding out what's missing in community access for individuals with disabilities.
Thank you very much. Jeffrey?
Good morning, everybody. My name is Jeffrey Nolish. My pronouns are he, him, his. And if there's anyone with vision difficulty on the Zoom, I present as brown skin, Latinx, Colombian American with brown eyes, black hair, glasses, and I'm wearing a light blue zipping kind of shirt. Anyway, I work for Detroit Disability Power. We're a membership organization that works to build the political power of the disability community. We are based in Detroit. We serve, I'd say, the Metro Detroit area, maybe a quad county or tri-county area. And we know that in order to end disparities people with disabilities face in regards to housing, employment, education, transportation, healthcare, et cetera, that we must organize. So if you're not familiar with our organization, Detroit Disability Power, please check us out at detroitdisabilitypower.org. And I'm so happy to be here. Thanks for inviting me, Michelle.
Thank you. Tameka?
Everybody's Tameka Citchen-Spruce, and I am the program assistant and the chairperson of the Inclusive Health Committee for Beaumont Health, Healthy Dearborn. So Healthy Dearborn is a healthy community, started as a healthy community initiative, one of 8 actually in Beaumont Health systems. And so our goal is to help Dearborn residents become healthier through like healthy eating, physical activity and such. And as I stated, we're divided into different action teams. And so the action team I oversee, again, is the Inclusive Health Committee. And so we're comprised of, people with disabilities, parents, and those who work with them. So our goal is to help Healthy Dearborn Coalition to be inclusive in all its programs. But then also we, do different activities. In Dearborn. So for example, so things that we've done is like recently hold webinars, for parents in the community on ways to be healthier. Also, was it like last year, we received a grant from the Michigan Health Endowment Fund to do a sports sampling program for disabled youth in Dearborn. So we're really excited about that. Unfortunately, we couldn't do that because of COVID last year. So this year we're hoping in the fall to start that program. So really excited about that. And I'm a community organizer for Wheels of Metropolitan.
Wonderful. Thank you, Tameka. Sheria, can you tell us a little bit about your research? And I know you work with several community organizations as well.
Yeah, good morning. I'm clinically a nurse and a faculty member over in the School of Nursing here at the University of Michigan. And much of my work focuses on care and services for older adults. And so my research is in that area, and I work directly with older adults and family caregivers, particularly as of late, people with pain that are managing chronic pain. And developing. I work with colleagues over in public health and a couple other schools at looking at how to develop culturally tailored interventions at this time specifically for Black older adults to improve pain management. And we've got some fantastic results with doing some of that work, which is exciting. I also work with family caregivers of persons with various forms of dementia to understand how to better support caregivers and reduce the number of people that may develop dementia in the future. I work with community groups to understand, one, what sorts of services that they're providing, and then to help to maybe reduce some of the duplication and expand services amongst groups. I do quite a bit of work with Ypsilanti Senior Center, Ypsilanti Meals on Wheels. And so really just organizations that service seniors. I also work with the Michigan Dementia Coalition group with the Supportive Services Committee, and have worked closely with many of the Alzheimer's Association groups, both on programming and particularly towards health equity and diversity for volunteers and staff. And I think on another somewhat related note, I also have a child that is autistic. And so I am in a lot of the other disability services that aren't necessarily related to my work, but more so advocacy and helping other parents to navigate the system, because I have a team. So particularly folks that have new diagnosis, trying to figure out how to navigate the education system and inside and outside of that, and hospitalized care and that sort of thing as needed.
Wonderful. Thank you very much. So obviously a lot of knowledge, a lot of talent, and a lot of people who are directly working with communities here. So can you start by talking to me about the intersection of race and disability? Often in conversations about race and racism, disability gets left out. And too often, even in conversations related to disability, the overlap and the unique issues of Black and Brown people with disabilities are forgotten. So
Well, I can start. So, as a associate fellow with the Pulse Institute, which is an organization in Detroit dedicated to researching the issues that face individuals in poverty in Detroit, being a person with a disability of color. You're right, Michelle. It does often get swept under the table, the disability. And even in some cases, it's hard to believe that. Well, it's not hard to believe for us here, but in many cases, individuals with disabilities get both desexualized and racialized in immediate interaction, although we don't see the deracialization in services. It's very difficult to be Black or brown and disabled in communities where there are higher incidences of poverty because the services are not as great. One of the things we learned in our research on our project is that there are not a lot of services that exist specifically for Black people or lower income people. For instance, in the city of Detroit, recreation centers, different ways for individuals to become socialized that don't necessarily directly relate to activism. So you'll find that many times it's difficult to engage with community in ways that service your whole spirit, I guess I want to say, in plain language. So sometimes it's difficult to find a place to have fun. For instance, in the city of Detroit, and again, that's a majority Black city with higher incidence of poverty, there are few, if any, parks, recreational parks, that are accessible. And as a parent who raised a young man in the city of Detroit with a disability, that was difficult for me. Seeing that I had to go to the suburbs, Dearborn, Southfield, to find a simple playground where I could take my son to play on the swings and things that I could move around comfortably. We do have, oh yes, go ahead.
I was going to say, so both the attitudes around and the environment does not recognize your aspects of your personhood or identity.
Very often that is the case. They don't.
Okay. Are other folks want to add to?
Yeah, I would like to add to it as well. I know growing up, as a young woman with, physical disability, I use a wheelchair due to a spinal cord injury. So, I went to a predominantly white school. And so, I had to, I experienced ableism, so attitudes towards my physical disability, but then also I faced racism from some of my peers as well, saying derogatory things about Black people in front of me too. And things like that got so bad. One time I had to go into the school to tell the school administrators, what was being said, and that person got suspended for 2 days. So like oftentimes when you're, a Black person or person of color with disability, you experience multiple things. I know my friend and mentee, who is Arab American young woman with a disability, she often tells me, like her experiences. And so like, she experienced these, be it attitudes towards her disability from school administrators and sometimes from her community. But then also after 9/11, teachers were making derogatory comments towards her and say that we don't speak the Arabic language here. So what I'm saying. So we oftentimes when you are a person of color, with a disability, you experience stereotypes from all different facets. It comes from all different way.
Okay, thank you. Jeffrey?
This is Jeffrey. I think what I would add to the discussion is that the idea of intersectionality, which was coined by feminist theorist Kimberly Crenshaw in 1989, was born out of the experiences of Black women who experienced both racism and sexism in specific ways. And this is a core principle of disability justice that simply states, each one of us on this Zoom call and everywhere are many things, and all of those things impact us. And depending on context, we all experience privilege or oppression in different ways. And this is really central to, I think, what we want to reflect on today and basically every day, which is, Dr. King's vision for a more beloved community. And although, Kimberly Crenshaw coined the term in 1989, King's vision of a beloved community had an all-inclusive spirit component to it. And one where we shared wealth, one where we championed truth and justice and goodwill, and something called agape, which is really a specific kind of love that is redeemable and lives in understanding. So I think that if you don't seek to understand people in a whole way, you're not going to be able to serve them in a whole way that can truly alleviate suffering.
Wonderful.
And this is Sheria. Along those same lines, I think that, intersectionality also speaks about, the multi-identities that individuals hold, but also the multiple stressors that come with the challenges of living in spaces that are often oppressive spaces, right? And so I think from the standpoint of looking at healthcare systems and organizations and clinicians and individuals in positions of power, it's really important to be thoughtful about one's own privileges that they hold and the ways in which we're able to use our spaces to uplift others, which means being able to think about the biases that we all hold and how they influence the ways in which we interact and engage with one another. And also thinking about the ways in which we can create more equitable spaces. And sometimes a lot of those things don't readily come to mind, which means that you have to surround yourself with people who can bring them to mind for you sometimes, which, speaks to the importance of having a diverse team that you're working with and thinking about diversity in all of the different ways that it means being around people who are different from you, from the way that you were raised, from the way that you were trained, from the ways in which you believe, so that you have a broad perspective in addressing problems.
Right. Thank you. So as you were, I think, going towards, what exactly does ableism mean and how do we see it in the healthcare systems? Jeffrey?
Sure, this is Jeffrey. So ableism is, the textbook definition is discrimination in favor of able-bodied people, which is terminology I don't even always know if I agree with, but, and I say that because government can be disabling, environments can be disabling, power can be disabling if used or misused. And so the way that it can show up in healthcare, I know many people on this Zoom can take this. But what I would add would be, it shows up in everything from bias and attitudes and stereotypes about quality of life and who gets what kind of level of service and who doesn't. It shows up in geography, who has access to local hospitals, local medical care, what quality of medical care. It shows up in the implementation of policy, healthcare policy, that is oftentimes written or put together by people that lack insight and or the goodwill, so to speak, to want to understand, going back to intersectionality and wholeness, the whole person, disabled or not. And so each of these components adds to the kind of community that we experience, and the kind of community that we're trying to still put together.
Yes.
Go ahead. Go
No,
ahead.
Jamie?
Oh, I was gonna say, so in my definition, and I agree with a lot of what Jeffrey said, thank you. I share the idea that government policies, neighborhoods and things of that could be disabling. But and I agree with his definition of ableism. Most individuals who study policy understand that ableism has a lot to do with the idea of racism or white supremacy, because we know this country was founded on the principles that all Anglo-Saxon property owning men were created equal. It did not take into account race, it did not take into account gender, and it definitely did not take into account disability, knowing that in many cases, individuals with disabilities were seen as not very much good to general society and or their families, so much so that individuals with disabilities were put out on the street to beg. Ironically enough, that's where the term handicap originates from, that and other people being seen as vagrants, using their caps to gain resources to care for themselves. So when you think about ableism, it's not just based on disability, it's based on gender presentation, it's based on many times your station in life. So classism plays a very huge role in the idea of ableism, because your zip code in many cases determines your access to services, as is seen far too often in most Black and brown communities.
And that's great. And I'd like to add to what, Jeffrey and JB say, that those are good, ways of, looking at ableism. It has how it shows up in, society for people of color with disabilities. And I'll just give, like a quick example of two instances where I believe there was ableism, so in the healthcare system. So one was when I was like 18, 19, but early, between like 18, 22 or so. And so when you're a young woman, you're ready to, go to a kind of colleges, to do women, ladies, type of appointments, something like that. And so when I acquired my primary physician at the time, the one I have now is excellent, but the one before him, and I inquired about, getting that type of appointment, she was like, oh, you don't need that. I'm like, I don't need that, and so, that just really took me back, that my primary physician would think like why, that I wouldn't need it. And I didn't go into detail, but I mean, I knew, why she said that, because, being a young woman and with a disability, she don't think it's important, for me to need that type of care. So that's an example. Another example is when my son went to the hospital for his asthma, and so the physician came in and he saw, me and then so my husband who also has, a disability. And so he looked at me, the doctor looked at me and said, "What's wrong with me?" He looked at my husband, said, "What's wrong with my husband?" And he looked at my son and said, because my son was hyperactive and stuff. So he looked at my son and said, "I think there's something wrong with him." And then he looked at my daughter and said, "There's something wrong with her." My husband. And I was looking like, what in the world? You're supposed to be servicing my son, looking, taking care of his asthma. You sit up there asking all of us what's wrong with us, making judgments. So, you have, when you experience things like that, like those social attitudes, from doctors, it's very disheartening, and it's like, wow, and that can interfere with the type of care, they give you, and the seriousness, how serious they take you, as well, because to them, they just see you as a medical model, somebody that needs to be fixed. And that's how some doctors that have experience have seen.
And so I'm glad you brought up the idea of a medical model about how disability and impairment itself is looked at as not as a part of identity, not as unique experiences or a unique part of who you are, but rather something to be fixed, and therefore someone who is, supposed to be adherent, compliant with the recommendations of a healthcare system rather than sometimes a partner in the process. And so a lot of the attitudinal areas, I'm sure, some of what was mentioned before by Jaime, the environment, not just of the wellness facilities, but healthcare facilities. And then relevant policies, as Jeffrey was mentioning. Where are the hospitals located? What type of reimbursement do they have, or what type of insurance do they accept? Sheria, want to add to this?
Well, I mean, I think that everybody's done a great job of covering some of the key areas. I think the thing that I would just add is that I think that, oftentimes when I hear people who do not have a disability think about, or I won't say how they, because I don't know how they think, but what we hear them say sometimes is it seems as though there's this idea that disabilities are inconvenient, right? Of course they're inconvenient. So if they're inconvenient for the person experiencing it, I think that we can handle some of the inconvenience that comes from individuals that need to develop accommodations, and they're costly, right? So if they're costly for persons experiencing disability, certainly the cost isn't generally going to be comparative for individuals that are legally required to provide reasonable accommodations for individuals. And I think that when we think about ableism within institutions, it means that we don't have the foresight in design and thinking about how to create accessible spaces that are physically accessible in a variety of ways for individuals. As we do renovations, we don't think about these sorts of things. And even within public institutions, we aren't very thoughtful about how to about individuals that may need additional accommodations to be able to navigate spaces. And so, of course, that's often frustrating. Even things that are small, like, for example, on campus, they redid a parking structure. and for some reason the elevator was out, but they didn't put any signage up. So you can park in handicap spaces throughout the structure. You get to the top and then you go to take the elevator down and the elevator's out, but there was no signage anywhere to say that. So now you either have to figure out how to get from the bottom all the way to the top, or worse, you had parked there not knowing that it was going to be out later, and now you can't get back to your vehicle, you know, but nobody thinks about these sorts of things because they're not, you know, that's the privilege of being, you know, abled and not having to consider these things, or even many of the doors that are on campus that, you know, are not handicap accessible doors that are difficult to navigate, which means that you can't even move around in buildings by yourself, you know, and be independent because that these specific sorts of things haven't been taken care of.
Thank you. So talk to me a little, Jeffrey.
Hi, Michelle. Sorry to interject. I just noticed in the chat that, you know, someone asked a question, you know, do we see attitude as a major problem or social stigma, and how do we think this can be mitigated?
Mhm.
And I think I want to tie this to Sheria's comments that, I mean, one, you know, are there attitudinal failures? Yes, but I feel like if you go into depth, there is a love failure. There's a consideration failure. The Rachel Carson, who wrote the book Silent Spring, said people will protect only what they love, and you had to, gosh, what did she say? You had to develop a sense of wonder to really achieve that love, and so she sought to achieve a sense of wonder about nature, and spread that knowledge, and people took to it, and that may have given rise or birth to the environmental movement. So in my view, you know, when we talk about attitude as a major problem, I mean, the love deficit is a major problem. And if you bring it back to the idea of agape, which is this overflowing love, spontaneous, creative love, that King called God operating in the human heart, then it doesn't discriminate and it doesn't make distinctions. And so, you know, when we talk about inconvenience, I think that it's not people that are inconvenienced, but the polity and how we organize society. And we need to do a better job as a whole doing that.
Right. Thank you. And maybe then with that, I'll just move on to that idea that how can we then create that respect and love at the different levels so that we can move forward together and we can create more accessible spaces, that we can be more considerate of one another, that we can be more inclusive with healthcare, with at the individual level, at the system level, and then at the policy level.
If I could speak to that, I think one of the things that we need to do as a society is understand that, understand the concept that what we do for the least of these, we do for everyone. The idea not of, I have to make it accessible for this person in a wheelchair, but I have to create a readily accessible world. Because even though today I sit in this seat, we know by statistics and just by human nature, we age into various forms of disabilities or limitations. So consider society as a whole. Not only do people with disabilities get left out of the policy conversations, the design conversations, far too often our senior population gets left out as well because we don't see we have a failure to see the validity of people that don't fit into our idea of what is desirable. And even when you look at the healthcare setting and going back to the medical model, I didn't want to take up the time with huge examples, but I can give one. When I was carrying my son, I had to be taken to the emergency room And while I was in the emergency room, the nurse recognized my disability. Instead of her comforting me because I was sick, she asked me, why did I do this? Who did I think was gonna care for myself and my baby? Because, and forgive me for this, but I must be on welfare, receiving assistance. So now my baby is gonna be another person added to the welfare rolls. And I will give for context, at the time, I had just graduated from college with my first degree and was working and was completely self-sufficient. I didn't receive any benefits at the time except for maybe medical insurance that was allotted me by the state because of my disability. But I was more than capable of caring for myself and my child. And at that time, I was actually financially assisting family members.
Right. And all too often we do hear this type of attitudes. So what would you do to begin to address that? Because it's not, I know it's not just that one case. I know it's not just that one person who felt able or that she had the right to judge and to say something and to then allow that to impact the care that she provided you. How do you think we can, what steps can we take so that doesn't happen?
Yeah, I was
No.
saying, sorry, I would say one example would be like Abby, and there's some examples at different universities that does this, but having people with disabilities, you know, working with a medical student, you know what I'm saying, as they, you know, going to school and stuff, so that in their practicum, you know, that they, you know, have work with actual people with disabilities. And so, you know, they get used to it and they will, you know, help them think outside the box and really see the people with disabilities as people.
And I'm wondering if that's what Jeffrey was saying about establishing that love, recognizing, building personal links to hopefully help the community care more and recognize more.
Absolutely, I would agree with that. I was gonna say thank you, Tameka, for saying that. The education factor, right? We're at a university that studies disability. Well, in all forms of academic tracks, there should be some sensitivity. We have cultural competence that covers ageism, sexism, colorism, and racial equity, but most often what is left out of that cultural competency conversation is the idea of disability or ableism. It's not included. And another way that could be solved is to consider that disability in and of itself has a culture. It is a culture for the person living it, much like a person who is a member of the LGBTQ community. That is their culture. That is who they are. That's how they experience the world around them.
Great.
And I think that one of the things that Tameka mentioned earlier that's really, or I'm sorry, Jaime mentioned earlier that's important, that circles back to a lot of this, is this idea of disability rooted in white supremacy culture. And that when you think about how we make decisions, and when we make decisions with the majority in mind, and as long as the majority is taken care of, you don't have to worry about the rest. That explains a lot why, you know, it's easy to do just that, right? So when we're planning, we're making decisions, we don't have to worry about, will this choice work for everybody? We can, you know, say, well, this will work for the majority and move on. And what we're suggesting is that in order to make these sorts of changes that we expect, that we have a right to, and that disabled communities have a right to, is that people have to start thinking and advocating more for, does this work for everybody? And if not, why not? and what are the specific things that we can do to get it closer to working for everybody realistically. And I think the more that we start to think in terms of that and get people to wrap their brains around this idea that we have to get out of this idea that stuff has to work for the majority, it needs to work for everybody, that we get closer to that. But for whatever reason, we have this idea when it comes to so many different policies and things that that's an impossibility, that we can't get to, you know, dealing with things that work for everybody. And I think that we have to get out of that, that there are ways in which we can get a lot closer to including everybody than we currently are.
Great, thanks. Jeffrey, back to you. Other ideas?
Michelle, will you repeat the question? Because I just want to be sure that I'm hitting the right policy notes.
Well, and so thinking about what are effective steps that we can do to begin to address and reduce, eliminate ableism and racism in healthcare, whether it's on the individual, the level of healthcare systems, or a healthcare policy.
Thank you. So I think how I would like to answer that is to take it in the direction of COVID-19 and share some policy that Detroit Disability Power is really working toward and advocating toward with others. So the state of Michigan, to my knowledge, doesn't track COVID-related disability data to the extent that they could or should. And this is imperative for understanding where the disability community is. And since we don't have that picture, I find it unacceptable. And so I understand that medical professionals or administrations may be challenged to think in a different way than they are used to, than the normal way they are used to performing. But I believe at a minimum, hospitals should be made to record how many patients with hearing or vision, cognitive, ambulatory, self-care, independent living, mental health, disabilities and difficulties, how many of these people have come through the hospital system and have been diagnosed with COVID-19. And I think that if you don't have that picture, then you're never going to be able to explore the kinds of correlations across social characteristics, race, sex, gender, any number of things, and uncover the kind of disparities that really need to be addressed. And you certainly won't be able to provide the kind of tailored solutions or interventions that need to be taken to help save lives. So I think one, it's critical that you seek out what the status quo is, and we don't know it right now. In my view, in America, we just learned recently, for instance, that people with intellectual and or developmental disabilities are 3 times more likely to die than someone other if they had contracted this disease, and people with Down syndrome are 10 times more likely to die. I mean, these are critical, important numbers, and these then speak to the reality of the vaccination process and what's happening and what's not happening right now. So without taking up too much time, we'll take one more minute to say, number one, you gotta track disability data. Number two, you really have to set up safeguards and protections against medical rationing, and they have to be rooted in non-discrimination, right? Ways that you can do this, you can require transparencies of hospital systems, that they have medical rationing plans that are inclusive, that don't allow for stereotyping about quality of life. You can make sure that these plans are committed to civil rights. And you can also establish clear protocol at the hospital to make sure that people are tended to in moments of discrimination in real time. If you don't have that kind of protocol, or if your patient advocate is overwhelmed, which they likely are if you're in a medical rationing situation, then you need redundancies there, especially for the most marginalized. I mean, that's the whole point of government, in my view. And the final thing I would say is that, going back to the vaccinations, we are hearing terrible, scary news every day. Everyone on this Zoom call is hearing it, right? New variants, new highest number of deaths per day. No one wants to hear this. I'm terrified, right? Me and my apartment. My mom and dad are on this call, and I haven't hugged my mom and dad, in over a year. That sucks. I'm sure everyone can agree that if you can't hug your family, we should be able to at least do that. So my point, I think ultimately, is that we need to be able to provide better for vaccination of the disability community in an identity-specific way. We need to allow for consent to vaccination. We need to make sure these vaccines are going to every kind of community facility. Maybe some offer care, maybe some don't. Maybe some are big, maybe some are small, maybe some are licensed, maybe some are independent. You got to hit them all. And then I would say that it's really important that we prioritize people with disabilities at the same level as people that are 65 to 75, people that are unhoused. And forgive me for wanting that. Right. Forgive me for feeling like that my sister who lives with vision difficulty and some health issues deserves vaccination before I do or before other people, because that's what my parents and my love taught me. So I think that you really have to take these kind of policy ideas to heart. You really got to fight for them every day. And if I were to say just 3 things, super brief about like positive, right? That where we are at, like, thank goodness that, Michelle, you put together the Zoom call. Thank goodness that we have badass advocates in Detroit like Tameka and Jaime. Thank goodness that we have healthcare officials that are aware, that care, that fight in the rooms that we are not in every day. And I'm very thankful to my boss, Esther Cosman, Detroit Disability Power, for allowing me to continue to grow in this space. It is a fantastic space, and I'm really thankful all of you are here to fight with us.
Thank you, Jeffrey. I think it's going to be hard to top that. I think that passion and that, that personal connection is exactly what we need. And that idea of, to the extent you can't be in every room, having other people who are at least aware of the issues and bring them up and then bring you in or bring someone else in. So please, I know we only have a few more minutes, but your other thoughts about steps. What would be the step that you would like to see about addressing health inequities, and whether it's COVID specific or broader? Tameka?
So one thing I did learn, which has been spoken about today, but one thing I learned at Healthy Dearborn, which I did not know before, is like the social determinants of health. And so, one thing that we have seen that COVID has done, it has really exposed, the huge health disparities within communities of color, particularly Black people and Black people with underlying health conditions too, heart disease and diabetes and things like that. And that is due to, the social determinants of health, which has been spoken about earlier today. If you don't have access, like environment, like access to foods and, good housing determines health as well, and just various facets of environments. And so I really would like to see that addressed, how we can end the disparities in that way, because I think that if we start with, closing the health disparities when it comes to access to various things, then, possibly we would see, better health outcomes.
So
for people.
healthcare systems partnering with communities to create social changes, to lift communities up, rather than just saying, well, of course, this outcome is because it's the nature of the community.
Yeah, and to start addressing the social environments that, affects people.
Okay, and taking responsibility there. Nice. Jaime?
I would agree with Tameka 1000%. I also agree with Jeffrey when he said that love has to be at the center of what we do. That's a way to alleviate. And start programs. Not only have practicums where medical students and nurses have face-to-face interaction with individuals with disabilities, but have people with disabilities co-facilitating classrooms, individuals with lived experience co-facilitating in classrooms where individuals that go into the healthcare system, go into the governmental system and things of that nature, working alongside a professor to give the human approach to academic learning.
So you're trying to take away the hierarchy or differences in status that might exist or be perceived and saying, you know, you're here as a service profession as well. You have to understand, you have to love, you have to respect the people that you're working with, and that there is a certain level of, you have to understand that who I am, who my family is just as important. That, you know, and in fact, I am, or folks who you see are your primary priority here.
Yeah.
And taking them out, okay. Or taking out the idea of, I get an opportunity to judge, or you are, I'm here somehow for you to fix, or for, yeah. So those pieces in terms of the attitude, the hope approach, and connecting with real love and humility in that process.
Yes.
Sheria, other thoughts about how the healthcare system can change? Or
Yeah, I mean, I think the things that I'm really hopeful for and would like to see is, I know that Biden had mentioned at some point about lowering the Medicare eligibility age, and I would really love to see that forward. We know that there's a difference in life expectancy that has clear racial lines with, you know, Black males in particular having the shortest life expectancy amongst the different racial and ethnic groups. And specifically as it relates to COVID, there's like an 8-year age difference in deaths between individuals of racial and ethnic minority groups and white folks. And so when we think about health outcomes, it would be fantastic to get more people access who are disabled to medical care, to perhaps increase their life expectancy. And as we think about vaccination rollout, we have to keep in mind that creating this age group to bump people up is still excluding a large number of individuals that fall below that cutoff number that still maybe have a higher risk both of exposure to COVID as well as severe consequences, you know, including death from COVID exposure. So I think from my perspective and the work that I'm doing, that's one of the large things that I would like to see is increase in access to healthcare services, including vaccination for people that are would be considered older, but don't fall into that 65 group.
Right, thank you. And I see that there's a question from Els about, do you think we need a uniform framework bringing together the complex issues? I would say, I know we talk about and we work with the ICF in terms of thinking about the role of environmental as well as personal factors within the, considering the disablement process and disability. It sounds like we're almost at a different place here. First, we have to understand and care, and then the steps need to go from there. The getting information about who are we, who has a disability, what type, can then allow us to have a better idea of scope, a better idea of issues, connecting with people, allow us to care. And then the idea of the creating tailored solutions, moving from there, and the tailored solutions at the individual level, at the level of education, and at policies, whether healthcare systems or insurance and healthcare reimbursement. So it's now a little bit after, it's now 9:47, so this is officially the end. Any final thoughts from our 4 panelists before we're signing off?
Just thank everybody for coming.
This is Jeffrey. I just would briefly say, when approaching framework, there are 10 principles to disability justice. They are intersectionality, leadership of those most impacted, an anti-capitalist politic, commitment to cross-movement organizing, reorganizing wholeness, sustainability, commitment to cross-disability solidarity, interdependence, collective access, and collective liberation. So yes, I speak a lot about love and agape, but I think that even if you put people, the right people at the right—
to send a message to that Robert Calico and tell him we found that he might be a first or second cousin.
Sure.
And see what he says.
Sure.
Someone was unmuted. Jeffrey, can you repeat what you were saying?
In summary, even if you put the right people at the right table, you really need to work together, to develop diversity of thought, right? And ways that you can apply how you care.
And Jeffrey, they're asking in the chat where that framework came from.
Sorry. Oh, so that framework is from Sins Invalid. Disability justice is really seen as like the second generation of disability rights, really developed in the last 15 years. And those principles really grew out of 2015. So, we're all working together to really try and figure out a way to do better for everyone.
Yeah, and I just thank everyone and Michelle for having me here. And just to reiterate what Jeffrey said, disability justice is a really excellent framework. It really, I know, helped me as an activist, and it really, help put words to what I want to see, as a Black woman with a disability. So I definitely highly recommend everyone to look at Sins Invalid and disability justice.
Wonderful. Jamie, anything else?
Thoughts. We need more conversations like this one.
Yep. Thank you. Thank you all for being part of here. Panelists, thank you for taking your time, for sharing your knowledge, and for being willing to share, your expertise and stories and experience. Everyone, have a good day. There's wonderful events going on today. Please take what time you can to be part of it.
Thank you so much.
Thank you.
Happy MLK. Bye-bye.
Thanks, everybody.